Okay, for those of you people who don't know me, my name's Herman Kwan. I'm a fourth-year resident here, and this is my debut for Urology Grand Rounds, so we'll try to have a little bit of fun with this. This morning I'll be speaking on the pathophysiological rationale for surgical treatments of stress urinary incontinence. I'm going to begin off the morning with a case. It's a made-up case, but I think we'll all agree it's a pretty familiar case. A 62-year-old female presents initially with urinary incontinence in 1999. She got a history, a physical, and she got a cystoscopy and urodynamic studies. The urologist involved diagnosed quote-unquote stress urinary incontinence, and after a few months of conservative therapy, a surgical procedure was performed. And unfortunately, she returns to your office this year with symptoms of urinary incontinence again. It's a fact that approximately 30% of the surgical treatments that we do today are in fact reoperations, and this was reported by Ulmsten in 1997. So I think as a surgeon, we need to ask ourselves why so many procedures are failing. And with any surgical procedure, you could probably break it down to three main factors: patient factors, procedural factors, and surgeon factors. So in this case, the patient factors would be over 6 years, perhaps the patient's age. She's sustained additional injury to her pelvic floor. Procedural factors, these could be maybe the wrong material was used. Instead of an autologous fascia, maybe they used some sort of cadaveric fascia. Maybe the urologist chose a procedure that was just prone to fail. Finally, there's surgeon factors, and in the area of incontinence, perhaps the urologist made an incorrect diagnosis, and also possible was the treatment that was given didn't actually address the pathophysiology of her stress urinary incontinence. So by the end of the morning, I hope to get through four main objectives. First of all, I just want to emphasize that we really have a poor understanding of the pathophysiology of stress urinary incontinence in women. It's definitely still evolving, and we're learning more all the time. I want to spend quite a bit of time introducing the single factor theories behind our understanding of stress urinary incontinence. I want to impart a more holistic view of stress urinary incontinence and emphasize that it's a multifactorial disease. And I want to introduce the concepts of shear force and something we call a continence threshold. And I think it really helps us understand what's anatomically happening when a woman's experiencing stress incontinence. And finally, I want to introduce the trampoline theory of female continence, and it's something I learned at a female urology course that I was lucky enough to attend in Florida at the end of February. So I thought since this is my debut at Grand Rounds, I thought it'd be a little bit controversial and put up a quote and maybe make a point for discussion at the end of the talk. I think we're tooting our own horn. This is a quote from Dr. Christopher Payne. If you remember, he was the female urologist that spoke to us at the Northwest last fall. Now, he didn't actually say this verbatim, but he basically, before his talk on incontinence, he said that urologists aren't doing a good job at taking care of the female pelvic floor. We're really good at solving the incontinence, but after you fix the incontinence, you're really predisposing them to other pelvic organ prolapse, and urologists seem to be turning a blind eye to that. So again, so in our literature, we have a lot of patients who are termed surgical successes, but I think we failed to realize that a lot of these patients continue to have a lot of problems. And maybe we can talk about whether or not we think urologists really should be taking care of the female pelvic floor, or if that's something we should be pushing. So this is a fun slide. I think that from a resident's point of view, the current therapy for stress urinary incontinence, it's totally empiric. Because like when I'm trying to read the textbooks, or watch what people are doing. One urologist ideal patient for a pubovaginal sling is another urologist ideal patient for TVT, and yet another's birch. So it really is a free-for-all. So let me just get this arrow. Sorry, it's not showing up here. Arrow options. Automatic? Visible? Oh, good. Okay. So that's us here. It is. Yeah. Yeah. Okay, fine. That's me. So, this.
Where's Howard in there?
He's there. So. Okay. I showed this slide because I think it's a really good summary of our understanding of the natural history of incontinence. And basically, this was a European study. They followed a group of patients who were first continent and also who were incontinent over 5 years, and they found that the incontinent patients, almost a quarter of them became continent. So there's a remission rate of almost 25%. So I think from this data, we should always keep in mind that patients that come to the office with mild, moderate incontinence, it's always worth a trial of conservative therapy because there are remission rates, and definitely from this data, urinary incontinence waxes and wanes. These patients both had, yeah.
They were not treated at all?
They weren't treated. Some of them got estrogen therapy, but for the most part, they weren't. It was just pelvic floor exercises, and yeah, they did their conservative management exactly. So, and they're, I'm sorry, 5 years, yeah, and this is actually a mishmash of both pure stress, and also urgent incontinence, mixed incontinence. So, stress urinary incontinence is definitely the most common type in women. It's about 50% of all cases of incontinence. Next most common is mixed incontinence, and then it's urgent incontinence. In men, these are totally reversed. Urgent incontinence is most common, then mixed, and then stress makes up quite a small proportion of incontinence in men. This is a good summary slide of all the risk factors for stress urinary incontinence. I actually modified this from the original article from Bump in 1998. In that original article, these risk factors are risk factors for pelvic organ prolapse, but I think it's fair to extrapolate to stress urinary incontinence. And they can be broken up into 4 major categories: decompensating, predisposing, inciting, and promoting factors. And interesting anatomic, or what we're interested in as urologists in fixing, is really just one factor out of many contributing to female incontinence. So the treatments that we have today are based on our current understanding of the pathophysiology of stress urinary incontinence. And truth be told, it's not well understood. So I don't think you've seen this picture before, Omar, but I dug this picture out because deficiencies in understanding the pathophysiology lead to failure of therapy. So, as Omar would say, who's a previous engineer, you can't fix it if you don't know where it's broken. Okay. This is just an overview of the physiology of continence. I'm not going to get into the details. Basically, just remind ourselves there's central control mechanisms and there's peripheral control mechanisms. Urologists are more interested in the peripheral control mechanisms because it includes the lower urinary tract structures. This is where all the investigation's going on, and it's the basis of most treatment modalities for incontinence in women. So the next few slides, I just want to go over some pertinent anatomy to help us understand the pathophysiology of continence and incontinence in females. We had a resident session last Friday trying to go over this, and I think everyone got a headache, including myself. It's hard to understand, and I think if we think that we really understand it, we really got to question ourselves. So on the left here, this is a picture from Netter, and it's the bladder in situ in the pelvis. This is the cut urachus. The bladder sitting on the pelvic floor. These are the levators here. And we need to remember that the endopelvic fascia, which is a continuation of the transversalis fascia, it covers all the organs in the pelvis. And the important landmark I wanted to show here was the arcus tendineus, which is actually the pelvic sidewall attachment of the endopelvic fascia. And there's actually two components. More medially, there's the arcus tendineus of the fascia pelvis. I'm going to be saying this name multiple times because it's just important that we really get this clear. And then more laterally, there's the arcus tendineus of the levator ani. Anyways, in the incontinence literature, they always talk about the fascia detaching right here, the arcus tendineus fascia pelvis, and this is where you lose the hammock. This is just a diagrammatic picture of the same. The bladder here, the urethra, it's sitting in this sling of pubococcygeus or the levators. And again, it's illustrating the tendinous arch here. And a really important concept in understanding female urology is that this endopelvic fascia, it's actually one continuous sheet of fascia, and it condenses into ligaments, and different names are given to this fascia depending on where you find it. So on Friday, I showed this diagram to the residents, and I think everyone got confused, but basically, the endopelvic fascia that you find above the levators, you can call that the endopelvic fascia. But then below the levators, it's still actually the same physical fascia, but it's known in the gynecological literature as pubocervical fascia. And how you can see it is this diagram is really good. It's from an old edition of Campbell's. You're looking at the perineal side of the pelvis. This is the levator here. And this is the urogenital hiatus, and this is the bladder, this is the urethra, and you can imagine the fascia coming in between the bladder and the vagina. This fascia here is called the pubocervical fascia, and up by the urethra, you would call it the periurethral fascia. Here, vesical pelvic fascia, and down by the cervix, the sacrouterine cardinal ligaments. This fascia is really important to understand if you want to understand why cystoceles form and how to repair the cystocele. So the picture on the left, this is a view of a woman in lithotomy, weighted speculum in place, Foley catheter in place. You can see the Foley here. The vaginal mucosa has been split down the midline and retracted laterally, and you can see the bulging bladder here. And the reason this cystocele formed was that there was splaying of this pubocervical fascia. They call it a different name here, but it's still pubocervical fascia. And on the right, that's just a depiction of the repair. It looks like some sort of bladder neck suspension and anterior repair. And these pictures I want to illustrate and emphasize the fact that the urethra sits on a hammock of anterior vaginal wall. On the left there, you can see that's the urethra sitting on this nice little hammock. And this hammock is supported laterally by its attachments to pubococcygeus, and also there's fascial attachments here to the arcus tendineus fascia pelvis. This picture on the right is a picture from Delancey, who gave us the hammock hypothesis, and it shows the same lateral view, the arcus tendineus fascia pelvis. This is the anterior vaginal wall supporting the urethra, and here this is the fascial attachments that support the vaginal wall. This picture shows, again, that the urethra really is sitting in a hammock. This is the arcus tendineus fascia pelvis, endopelvic fascia coming down in between the vagina and the urethra. And here it's actually detached. And this could predispose someone to a lateral defect cystocele, and this would need to be repaired either vaginally or transabdominally. This picture is in our current edition of Campbell's from Dr. Hirschhorn. I think it's a great picture illustrating the fact that the urethra is really on a double hammock. The urethra is here, the anterior vaginal wall supporting the urethra, and what we mean by double hammock is that the vagina is supported first by its attachments to pubococcygeus laterally, or the levators, and secondly, there's a second reinforcement by the fascial attachments to the arcus tendineus fascia pelvis. And these pictures on the right, this one shows the external sphincters of the female urethra. We know that there's these strap muscles here, and also there's the urethral rhabdosphincter. I think the exact function and role of these muscles aren't clearly defined, but these strap muscles might be important in the mid-urethral continent zone that we always hear about. And finally, this picture is a picture from Shlomo Raz's atlas. It's a lateral view. This is a pubic bone, the urethra here, bladder, and I'm showing this picture because I want to show the pubo-urethral ligament. This is the ligament. It fixes the proximal urethra firmly to the pubic bone, and this is important because we always hear terms descensus of the bladder and rotational descent. And what does that really mean? Well, it's when the bladder gets forced down from a Valsalva maneuver, and it's pivoting around a fixed point, and it's from this pubo-urethral ligament. Yeah, sure.
So if we're doing now the internal diversions for the female, so we'd have to leave all this bottom part and just go way up above there, very close to the bottom neck, wouldn't we?
Yeah, I would think so, because the continent zone really is distal.
Stick down the pubic tubercles and so forth.
Yeah.
You made a mistake. That's good.
We'll talk about it later, but everyone used to think the proximal portion was the most important for continence, but it's really the distal. So, yeah. So, the factors for stress urinary incontinence, we hear all these terms thrown around all the time: bladder descensus, hypermobility, ISD, rotational descent, pipe stem urethra, hammock hypothesis, mid-urethral continence zone. There's a lot of terms here, and we really have to ask ourselves, how do these terms help us understand the pathophysiology? So here we go. The single factor theories on the pathophysiology of stress urinary incontinence. I'm going to talk about first the position of the proximal urethra, which is the theory that urologists understand the most. Then we'll talk about ISD. We'll talk about the hammock hypothesis, and finally we'll talk about the integral theory, which is actually the theory that is behind the TVT. So the urethral position theory was coined by a man named Gorhan and Horning in 1961. And essentially, he did urodynamics in normal women and women with stress urinary incontinence. And he found that during stress, increases in urethral pressure in women with stress urinary incontinence was not as great when compared to women without incontinence. And his hypothesis was that the absence of additional pressure to the urethra during stress was due to the urethra's extra-abdominal position. So this is a classic picture. I think it's from Blavius. It's lateral view, the bladder. This is the pubic bone. This dotted line is an imaginary pelvic floor. And this white balloon is a bladder in good position. And the black balloon is the bladder under a stress maneuver. And what he thought was that when the bladder descends below this theoretical pelvic floor, you get inadequate transmission of pressure to the proximal urethra, and you get leakage of urine. And this is actually the way that we were taught in medical school, or I remember lectures when I was in medical school, that this is why females got stress urinary incontinence. Again, in the normal female, the urethra should be well supported and in a retropubic and intra-abdominal position, and it shouldn't change with stress. So here, the proximal urethra is intra-abdominal, and during stress, you get compression of the proximal urethra. When the urethra is hypermobile, the urethra takes an intrapelvic position, and during a stress maneuver, you get inadequate transmission of pressure and you get leakage. This theory, again, I think it's the one that we understand the most and the one we talk about the most. It formed the basis for all the retropubic suspensions. The first reported was the MMK in 1949, and eventually this was modified by Birch in 1961. Then there's a whole rash of needle bladder neck suspensions: Pereira, Stamey's, Giddy's, and Raz. But even in the 1960s, people were starting to question the urethral position theory, and there's this report by Greenwald. This is a direct quote: "No correlation. There's no correlation between the intra-abdominal position of the bladder neck and stress urinary incontinence." And from a more clinical standpoint, we all know that there's a lot of women with hypermobile urethras who are continent. And also, we often see women with large distal urethroseals, and they stay continent. Then in the early 1980s, there was a man by the name of Constantinou. I'm not sure if he's a urologist or gynecologist, but he did some really elegant urodynamic studies. Again, he studied women with stress incontinence and then women without stress incontinence. Essentially, he recorded urethral profile pressures and transmission of abdominal pressures in the continent women, in the stress incontinent women, and then also in the women who are stress incontinent but got a STAMI needle suspension. And this is a summary of all the data that he accrued. And actually, this was reported in the urologic clinics in 2002, like some 20 years after it was originally done. So I think it shows how important this work really was. So the x-axis here, this is the female urethra, and at 0, this is the bladder neck, and at 100, this is the urethral meatus. In a normal female, this is normally 4 centimeters long. The y-axis here is the ratio of pressure between the urethra and the bladder. And essentially, we're trying to illustrate the efficiency of the transmission of pressure from the bladder or from the abdomen into the urethra. And you would think if there's good transmission, it should be 1. It should be equal transmission. So what he found was that in normal subjects, again, our 3 groups are down below. In normal subjects, he found that the highest zone of pressure transmission was in the mid-urethra, or even just a little distal to that. And in fact, this pressure transmission was more than 100%. It was about 165%. In women with stress urinary incontinence, this ratio never exceeded 100%, which is expected. Urethral pressure never exceeds the bladder pressure. And in women who were stress incontinent initially but had a bladder neck suspension and became continent, we found that the highest zone of pressure transmission was actually in the mid-urethra, which was a little surprising because everyone thought all the action was at the bladder neck. We thought that when we're lifting the bladder neck, we're really helping at the bladder neck, but it's actually helping in the mid-urethra. So in summary, the point of maximal pressure transmission is in the mid-urethra, and again, this is almost always below the pubis. After a needle suspension of the bladder neck, the mid-urethral hump is reestablished. And finally, he concluded, it's not actually illustrated on that table I just showed you, but in a subsequent study, he found that there was likely a separate neuromuscular reflex that caused that pressure transmission to be more than 100%. Remember, we saw 165%. He thought that there was a separate neuromuscular transmission that was responsible for this, and he thought that there was that. In fact, he found that the urethral pressure actually preceded the rise in the intravesical pressure, which gives more evidence that there's actually a separate mechanism there's a separate mechanism that causes this hump. And I think that it's probably from those strap muscles we saw, but I'm not sure.
Are you saying that's a spinal arc reflex or voluntary contraction?
It's a spinal arc reflex. Yeah, that's what they thought. Okay. Ulmsten, basically the inventor of the TVT, wrote this pretty inflammatory article in 1992. He basically criticized urologists, urogynecologists, and said, little advance in the surgery of stress urinary incontinence over the past 20 years from uncritical acceptance of the intra-abdominal pressure transmission theory. Okay, next, we'll talk about ISD, intrinsic sphincter deficiency. In the 1980s, Edward McGuire introduced the concept of ISD.
Is that what it looks like now?
I don't know, it's the only picture I could find of him. Really? So, basically, his theory was based on his urodynamic observations of women who failed anti-incontinence surgery. And he thought that there was an intrinsic problem from having multiple surgeries in the urethra. And this is a really important concept because we still use it today. These patients with stress urinary incontinence with a fixed urethra, we call these patients type 3 stress urinary incontinence. And his theory was based on sound science, from what I can see. In 1977, he published this article called The Effects of Sacral Denervation on Bladder and Urethral Function. And in the top frame here, we see there's a urethral pressure profile here, and here this is an EMG of the pelvic floor. And basically what he showed was he did sacral rhizotomies on quadriplegics who had intractable detrusor overactivity. And he found that after he did sacral rhizotomies, the pelvic floor is totally relaxed, like you lose the pudendal nerve, but you still, the urethral pressure profile is about the same. So he concluded that the urethral smooth muscle function alone provided satisfactory urinary incontinence. And interestingly, after the sacral rhizotomies were done, those patients, you could do a Crede maneuver, you still couldn't make them leak because that intrinsic continence function of the urethra kept them continent. This was a very important paper published by McGuire in 1993, and essentially this paper sprung onto us the idea of the Valsalva leak point pressure. What he showed with this paper was that the maximal urethral pressure, or urethral pressures in general, actually aren't that important in understanding how well the sphincter is actually working. I think back then people used to think that people who had a low urethral pressure had poorly functioning sphincters and thus had bad incontinence. Well, this study showed that that's not true. He showed that the pressure that was important is the abdominal pressure required to induce leakage. And here, people with low abdominal leak point pressures between 5 and 60, their maximal urethral pressure was about 29. In patients with high abdominal leak point pressure, their maximal urethral pressure is about 32. And these in fact are not statistically different. What he did find was that patients with low abdominal leak point pressures, they tended to have high-grade incontinence when compared to the patients with the higher leak point pressures. It's not shown in this table, but it is shown in the study. Just you have to take my word for it. So again, conclusions. Maximal urethral closing pressure does not correlate with severity of incontinence, thus sphincter function. But he did find that the abdominal pressure, or the Valsalva leak point pressure that required to induce leakage, did predict the severity of incontinence. So if you had a low Valsalva leak point pressure, those patients were likely to have very severe incontinence. Again, the Valsalva leak point pressure, it's a urodynamic tool to assess the competence of the urethra to resist increases in abdominal pressure. There's a definition: high-grade leakage with a low leak point pressure and a minimum bladder volume of 150 cc's. And also there should be an absence of a bladder contraction. Conceptually, we can think of ISD as this. This is like I think you would call this a stovepipe urethra. It's a very non-functional urethra. It's just one little bit of functioning mucosa. So you can imagine this urethra just would not coapt. And there's a lack of a urethral washer. And he believed this problem could be improved with his McGuire sling and the pubovaginal sling, or with periurethral injections. And still, this ISD was important because it divided patients with incontinence into those with ISD or those with hypermobility. And conceptually, it was helpful at one time. But the limitations are that ISD and hypermobility are not mutually exclusive because they definitely coexist in the same patient. We know that from radiologic studies that there's some women with open bladder necks who remain continent, and a patient with hypermobility and leaks has ISD by definition because a urethra should be able to resist any leakage regardless of where it's positioned. So the bottom line on the Valsalva leak point pressure today, it's a continuing source of confusion, I think, for a lot of us. The technique used to measure it's not standardized, but a bump said in 1997 that it's still a useful test and its clinical utility is proven, and it's definitely replaced urethral profile pressures, which are definitely falling out of favor. I think urethral pressure profiles are more common in gynecology. But I showed this slide to Senator Hirschhorn when he was here last week, and he actually totally disagrees. He doesn't think Valsalva leak point pressures are very useful at all, so even more confusion. Okay, the hammock hypothesis. This is from John Delancey. He's a gynecologist from Michigan, and he's the person who gave us this hammock hypothesis that we're always talking about. Essentially, he studied cadavers, fresh and embalmed, and he found that the urethra lies on the supportive layer of vaginal wall and also endopelvic fascia. And he studied this by actually taking these cadavers, and he put bags of plastic water to put stress on the urethra, and then he would study the urethra and the associated structures. So I think it was a great study. And again, this picture, I just show it again because it's just so helpful. The double hammock, urethra, anterior vaginal wall, the vaginal wall supported by pubococcygeus, and then in turn the vagina is also supported by fascial attachment to this tendinous arc. So this whole hypothesis states that if you have strong tissues below the bladder neck and proximal urethra, you get this backboard which allows the urethra to close and preventing stress urinary incontinence. And this picture really illustrates the hammock hypothesis well. So in A here, you have a strong backboard, and with a stress maneuver, you get closure of the urethra, no leakage. In B here, you get a weak backboard. During stress maneuver, you get opening of the urethra. And in C, this shows why some hypermobile urethras can remain continent, because even though this urethra is below the pubis here, the backboard is still very strong, so you get good closure of the urethra. But even from his original article in 1994, Delancey acknowledged that his theory was not the end-all be-all. He acknowledged Constantinou's observations that there was possibly a neuromuscular reflex contributing to increased urethral pressure, and he admitted in his original article that the greatest pressure transmission was in the mid-urethra, and that abdominal pressure transmission occurs mostly at the proximal urethra. Okay, finally we get to this integral theory introduced by Ulmsten, the inventor of the TVT. This is really confusing, and when I showed this to Dr. Hirschhorn last week, even he said that after 15 years he's still confused about this theory. But essentially what we have here, we have the bladder and we have the anterior vaginal wall. And this theory is based on 3 vector forces acting on the anterior vaginal wall. So anteriorly it's being pulled by pubococcygeus, posteriorly by the ureterosacral ligaments, and inferiorly by the longitudinal muscle of the anus. I'm not really sure what that muscle is, but that's what they called it, longitudinal muscle of the anus. So basically this theory suggests that the pelvic muscles are actually playing a very active role in maintaining continence, as opposed to the passive role of just the suburethral hammock. And as well, this theory tries to explain why a lot of women with stress urinary incontinence also have urge incontinence. And essentially, he says that stress and urge symptoms come from the same anatomical defect, which is a lax anterior vaginal wall. So just going back to this, remember these 3 vector forces on the vaginal wall. He said that if you lose one of these vectors, you lose the tight drum effect of the anterior vaginal wall, and then you get firing of nerves, and then this triggers a micturition reflex, and you get urgency frequency. You also get incontinence because you get inefficient closure because you lose these 3 vector forces causing a tight anterior vaginal wall. So this picture I just want to show just how the TVT works. Basically, when we put a TVT in, you're basically establishing the integrity of the pubourethral ligaments. And here the tape's in place, and the TVT uses the hypermobility of the urethra to its advantage. So during a stress maneuver, you get hypermobility and you get kinking. So you put it all together, you get rotational descent, hypermobility, ISD, suburethral support of the urethra, and an integral theory, or integrity of configuration. This all leads up to an incontinence threshold and shear forces acting at the bladder neck and anterior vaginal wall. And I think this is our most current understanding of what's actually happening on an anatomical basis when a woman's leaking, or at least this is my interpretation of it. So this incontinence threshold, this is a classic picture, lateral view, pubic bone here. And I'm showing this picture because I want to illustrate that the normal bladder is tethered to the pubic bone by the pubourethral ligaments. And again, when we talk about bladder descensus and rotational descent, the bladder is coming down this way, and it's rotating around the fixed point, the pubic bone, because of this pubourethral ligaments. The anterior vaginal wall during the cough or the stress maneuver has a lot of kinetic energy, and they've done radiological studies that the posterior urethral wall is actually separating from the anterior urethral wall, and you get this funneling effect, and this is actually what's happening when a woman's leaking. So essentially, you get this shearing effect at the proximal urethra because of the kinetic energy of the anterior vaginal wall. So whether or not this posterior wall separates from the anterior wall depends on all those factors we talked about, where the urethra is positioned, the intrinsic function of the urethra, how well the pressure is transmitted, and the integrity of the configuration. So I think this is the most current understanding of what's actually anatomically happening during stress urinary incontinence. So I guess we're finishing early, but our conclusions, I want to emphasize this, that stress urinary incontinence, it's not a single factor disease, but it's a spectrum of complex anatomical and physiological disorders based on central and peripheral control mechanisms. The physiology of continence is multifactorial, and so is the pathophysiology of stress urinary incontinence. And I want to introduce the concept of females having a continence threshold, and that incontinence occurs when this threshold is overwhelmed. And I want to introduce the fact that you get this shearing effect, pulling the posterior urethral wall away from the anterior urethral wall at the continence threshold. And this occurs when the walls are separated, when you get a poorly positioned urethra or lack of a hammock, when the urethral washer is damaged, when you have ISD, finally when the overall support structure is damaged, when you get damage to the pubourethral ligaments and the hammock. We need to adapt a more holistic view of stress incontinence, and I want to introduce this trampoline theory, which I learned at this female urology course in late February. And essentially, they thought a good way of thinking about female continence is actually a trampoline and not a hammock. You can imagine that all those factors I talked about before, they can compose these rings that support the trampoline, and that, you know, if you lose one, you still might have support of the trampoline, but eventually, when you lose enough, the trampoline fails. That's all I have.